recording. All right, we are recording. Let me go back down, back to here, here. Let's see if we can get by with this. Just waiting on this to load. Miss Drewby, you would know if you weren't. Although, Miss Drewby, it would be nice if you would start putting the date that the lecture was recorded. That would be good. But yes, you look. Miss Drewby, you would know if you weren't okay. I do see them from you. However, you did not put in the subject line what date the lecture was recorded. You put other helpful things like chapters, so that's fine.
Okay, I'll do that in the future.
Thanks, Drew. You're a gem. All right, let's get to not this module yet, but this one. All right, geriatric emergencies. This is going to go, I hope, pretty quickly because there are some high points. These chapters have to be read, as all of them have to, but again, this material that you're going to see on the quiz is fairly macro, so I'm going to cover the big parts that I know you're going to see, and more importantly, you're going to need for practice, and you are going to read the chapter. So hopefully that will speed the lecture itself along, and we can get into the first chapter of operations, which I'm hoping to do tonight. So obviously we're continuing our special populations module, which is an information space about tailoring our care to meet the demands of some specific people we see. And we think of immediately the very young and the very old, and we talk about the fact that they're kind of the same. My grandmother used to say, and I think I've told you this before, that you are once an adult, but you are twice a child. And what that means is that you come into this world a child, and depending how long you live, our brains don't tend to leave the world fully intact. Now, some people do. And we're thankful for that, but a lot of people towards the end of their life will need care similar to the care that you had to provide folks that were less than the age of 12. They will need to be looked after. They will need to be checked on. They will have to have their medications handled. This is not always true. And one of the things that the chapter wants to make clear is that although there are commonalities to older people, you should not assume anything. We think about Betty White. We think about the Queen of England. There are many people you can think of that get very high in age and leave this world with what appears to be a fully intact version of themselves. But that is not true for a large amount of the population. As we age, our organs do get smaller in size. This is called organic atrophy. The brain in particular. And the function of our organs becomes less efficient. And so you are going to see quiz questions throughout this particular chapter that talk about that function change, that our organs may shrink and that they may decline in function. We're thinking about the kidneys, for example, not filtering as well. So then this population is susceptible to stacking prescription medications. What do I mean by that? If I give you a drug and you take one pill of it, I can give you a time frame in which that one pill will have been fully metabolized by your body and it will have been secreted and it's no longer in your system. Well, that doesn't apply to older people because their metabolic rates are slower and their filtration rates through their kidneys and through their liver are also slower. So the way that they excrete chemicals, medications, nutrition is a slower process. And that comes along with some challenges. So we're going to talk about that a lot. We're going to talk about the commonalities of some prescription medications that get them in trouble. So if you're taking notes, we'll start with, let's just go through the slides. We'll go through the slides and we'll hit it as we go through the slide. So we talked about this, that the organs change and they decrease a little bit. The difference between Alzheimer's disease and dementia. Hold on 2 seconds.
You are now muted. You are now unmuted.
So Alzheimer's disease, or old-timers disease, as some people call it, is a disease of the brain itself. You're going to have to pay attention to that as it compares to dementia and delirium. We've talked about the difference in dementia and delirium in the past. Delirium is defined as an acute state, and dementia is defined as a chronic state. When you talk about a dementia patient, everyone knows they have dementia, and the family is aware of what their normal is. What can they normally think of? What questions can they normally answer? That is dementia. Delirium is sudden and would be associated more with psychosis, excited delirium, should you believe in that, maybe altered blood sugars. Metabolic disorders, thyroid disorders, that would be a version of delirium. So know the difference between delirium being acute and dementia being chronic. Alzheimer's disease should be accompanied with maybe the symptom of dementia, not delirium. So when you get called to an elderly person who has a history of dementia, it's important that we try to decipher, is this new? Is this a change in their normal? This particular module talks a lot about what is their normal, whether that's a development normal in the peds section, or if this is a dementia patient, an Alzheimer's patient, and they called for altered mental status. Well, what is their normal altered mental status? And then what changes prompted you to call us today? So it can get difficult. Even when we think of stroke, if someone's had a previous stroke and today we get called for a stroke, it's very important to find out what deficits they have every day, because those would need to be removed of our acute assessment to find out what is new. The same is going to be true for dementia patients. Okay, thinking about the fact that they commonly have heart disease, commonly have lung diseases, commonly have diabetes, commonly have renal failure or a decline in renal function. So you got to think about that. They're very susceptible to abuse and neglect, and that's simply because of what I told you. They're very young and the very old need similar care. And so in the talk of that, some people neglect it, or they don't provide that care, or we're not ensuring that there's groceries in the house, that there's appropriate air conditioning, that the activities of daily living, which is a big word you need to know, ADL, is activities of daily living. We need to make sure that we know who does their activities of daily living. Is it them? Do they bathe themselves? Do they cook all of their meals? Who ensures the patient is okay? Let's reach out to that person and make sure that that's not being neglected, because that's really important in the later stages of life. Continuing on. Again, we want the book is telling us that we don't assume that all old people are blind. We don't assume that all old people can't hear. We don't assume that all old people can't remember or have dementia or have Alzheimer's. You make no assumptions, even though we know that there are some commonalities. Okay? So think about that. Think about the fact that this person needs to be eating. This person needs to be going to the bathroom on their own. If they can't do that, that's a big deal. Urine and defecation causes significant breakdown in the skin. If a person cannot go to the bathroom normally, you can kill that person very fast. And so, one of the things that gets overlooked because it's so everyone can do this in our heads is whether or not a person's going to the bathroom on their own. If someone can't help them to the bathroom, or if they can't go to the bathroom on their own, we need to stop there and figure out how that's going to happen. Do we need to report this to social services? Do we need to tell this to the family? We need to make sure we think about activities of daily living. This is some communication techniques on how to be a good human being. I'm not going to read that for you. You should be able to not yell at the old people because they're old. I'll let you read on that. This is the common history. Sample and OP QRST is really important to these patients because what has happened to them before is likely to happen to them again. And so digging into their sample history, digging into their medications is going to help us figure out what's going on with the patient. That's for sure. All right, talking about the changes in the body, they're not as good on taking big breaths. So that's a big thing to think about with the literature and the quizzes. They're also going to have smaller brains, not bigger brains, and they're going to have less powerful brains. So keep that in mind. And since they're not taking big, deep breaths like the rest of us, they tend to set up pneumonia. You need to know that old people do not get fevers as well as young people. So, in the case of a severe infection, they may not present with a fever as you would expect to see in other populations. That's a big thing to remember with this population. The most common way they present with sepsis or significant infection is altered mental status. In a otherwise healthy middle-aged adult, you would find a raging fever as a commonality in sepsis. Not true in the elderly population because we lose that capability as we get higher in age. So don't forget, altered mental status in elderly people commonly means infection. If the blood sugar's okay, the oxygen level's okay, and you can't figure out what's going on, it might be an infection. Okay, so look at the heart rate. Is it high? Look at the blood pressure. Is it high? Do we see a compensation thing here? Pay attention to that. Elderly patients, especially female elderly patients, are extremely at risk for UTIs causing sepsis. Urinary tract infections causing blood sepsis in elderly patients is a pretty big deal. It happens to them a lot. So we've got to pay attention to that. Remember that they present with altered mental status not very well with fevers. Okay? Not as much with fever. Their arteries get blocked by atherosclerosis and high cholesterol. So as we get older, our hearts work less efficiently. And so in the elderly population, we tend to think that everyone above the age of 55 needs a 12 lead. Now, that doesn't take place as much in the pre-hospital setting as it does in the hospital setting, but you need to know that as we age, our pain receptors are not as direct. They don't send the messages as efficiently. They kind of take left and right turns and go to the wrong place. And so we're very cautious with weird, painful presentations in elderly people. It's not uncommon for an elderly person to have a heart attack but be complaining of arm pain or complaining of shoulder pain. And that's because as we age, the nerve endings don't talk to each other as well. They're not as connective. And so you may not have your common book complaints setting, chest pain in the center of my chest, substernally, feels like an elephant, radiates to my left arm and jaw. That may not occur in the elderly population, especially in the female elderly population. We think of them as being outliers because they don't follow the rule book. So when you open up the book in the medical module and it says that the symptoms of pulmonary embolus are the following, you got to be cautious in the elderly population because they don't tend to have the book symptoms. You've got to dig a little bit more. You've got to investigate a little bit more. And so keep that on the forefront of your thinking when you're doing a sample in an OPQRST and a secondary exam on the elderly, because they don't talk pain the same as the younger population does. They will commonly have heart failure, so make sure you're listening to lung sounds. If there's rales in the lungs, don't forget your CPAP. You are going to get questions again about which side of failure backs up where. And if you remember the blood flow through the heart, then this is not a problem for you. The right side of the heart receives its blood from the periphery, and so then that's where it'll back up. The left side of the heart receives its blood from the lungs, and so then that's where it will back up. So if you see a test question that simply says which type of heart failure is associated with pulmonary edema, then it would be left heart failure because the lungs give the blood to the heart on the left side. And so that should be an easy question for you if you've done your homework and you know how the blood traverses through the heart. Stroke is a big commonality in them. Heart attacks is a big commonality in them. You need to also remember that they do not respond very well to trauma. Elderly patients do not respond well to trauma. They will be shocky faster, but they won't really show you, okay? It doesn't take as much blood loss in them to be more hemodynamically unstable, but they're not as good at showing you shock. And here's why. Polypharmacy. Okay, polypharmacy is when a person is on a lot of medications to treat chronic illnesses. The problem with polypharmacy is that those medications will inhibit your ability to maintain high heart rates. And if you can't maintain high heart rates, then you're not getting a good compensation. The way we find people in compensatory shock or compensated shock is that they have high breathing rates and high heart rates. Well, if I'm giving you medications that keep your heart rate low, that keep your blood pressure low, then you can't show tachycardia. So you might look at a trauma victim that's 80 years old and say, well, their blood pressure's fine, their heart rate's fine. Well, you can't really trust that in this population because they're on medications that might fake their blood pressure. It might fake their heart rate when it otherwise would have been tacky. It would have been showing early signs of shock. So you have to be more conservative in the elderly population. I hope you're writing down these little tidbits because you're going to need them. You're going to remember these. You're going to go on a call and you're going to see a patient who has a heart rate of 80 when they've been, in a significant motor vehicle accident. And you're thinking, how could that be? Well, that's the medication. You can't trust that heart rate. You have to be conservative, and if the mechanism is big, then you've got to pull the trigger, as we say. Anybody over the age of 65 in the world of trauma, we will pull a trauma trigger on an age over 65 with almost nothing as a mechanism because they're so susceptible to trauma. As we age, our bone density gets worse, and so we don't have as much rigidity in our bones. They break easy, and when bones break, then we bleed. And if we're bleeding and we've got broken bones, then it's clear that this patient is going to have a symptomatic response. And then on top of that, you got all these medications keeping the patient from any type of good compensatory response. And so I hope that conversation makes you, get ahead of the ball and say, that blood pressure may look okay, that heart rate may look okay, but that vehicle that you were in is destroyed. And so I'm going to take you to a trauma center because I'm not sure. Remember that we cannot see injuries on the inside. And if we know that their muscles get weaker as we age, our appendages that hold the organs in place inside of our bodies, those get weaker, and then the vascular structures are not as healthy, then it's easier for them to set up internal bleeding, especially with high rates of speed and significant energy mechanisms. So you've got to be way more conservative with the elderly population. Always ask the elderly population if they have been on blood thinners. When it comes to falls, always ask the elderly population what made them fall. Did you trip over the rug, trip over the curb? Did you trip over the grass? Or did you get dizzy and pass out? Because that's a whole different thing. If you got dizzy and passed out, then this is not simply a fall. This is a medical event that then led to a fall. And so that's a significant thing to consider. The book wants you to know that the nervous system breaks down, as we've already discussed, and that may make their pain receptors much less externally and internally, which we've discussed. So they could put their hand on a hot oven and not feel it for a few more seconds than you or I, which leads to further injury. They'd get more injured than we would. Our reflexes would be faster and stronger, and so then we wouldn't get as much of an injury compared to an 80-year-old person who touches a hot stove and it takes a second for them to realize it was hot. So think about that. I'll let you read that. The difference between dementia and delirium, we already said that. You need a sugar on every one of these patients. Ari, do you have a question?
Yeah, we can't see your screen.
You can't see my screen? Can anybody else see the slides?
You're on neuropathy, right?
Yeah, I am. So Ari,
I can see it.
that must just be you. So go ahead and refresh your connection here.
Okay, hold on.
Everyone else can see my screens, right? I hope so, because
I can see it.
you should have spoken up way sooner. Okay, good. All right. So neuropathy is exactly what we just discussed. It's the breakdown of peripheral sensory because of age or medical conditions. So good job, Ari. Worried me to death there for a second because I was moving along. GI, they take a lot of pain medications, and pain medications make you constipated. You guys, I'm going through this information really fast, so write down what I'm saying because it's really important. So if they're on opiates like Lortab, oxycodone, morphine, they're going to get constipated, and that can lead to some complications. Ari, are you okay? You had your mic on. Okay. GI bleeds are a big deal with them, but not normally are they emergent. Anyone who's been taking a lot of ibuprofen, goody powders, naproxen, tramadol, alcohol use in the elderly population, that can all be precursors to GI bleeding. When someone complains of something, you start asking those specific questions, and it leads you down a road. Well, yeah, I take goody powders twice a day. Well, that's pretty heavy on your system. So then if the person's complaining of a possible GI bleed and they tell me something like that, then it begins to add up to, well, then this probably is a GI bleed and we should take it seriously. We talked about the fact that they don't secrete very well, so they're slowing down their renal system and hepatic system. They're more susceptible to illnesses. We talked about the fact that their bones break down. You need to know what osteoarthritis is. It is basically inflammation of the bones and weakening of the bones. Osteoporosis is decrease in bone density. So that's what makes them more susceptible to fractures. You should always be very cautious with leg pain, hip pain in the elderly population because even walking around, depending on their age and depending on some particular medications that we found out increase the loss of bone density, that could result in fractures just by walking. We know now that some antifungals, for example, increase the loss of bone density in the elderly population. So there's a lot of reasons why they might encounter fractures just moving along. Remember that their skin gets very thin and it is no longer as able to keep them warm or keep their fluid in the right place, and it's more susceptible to the external environment. So keep that in mind. We need to keep them more warm. We need to be careful about blisters in their skin and skin tears. When you move them along the stretcher, make sure you tell them to give themselves a hug. Don't let their elbows and their arms kind of hang on the side of the stretcher as you go down the hallways of their house, because you will catch those hallways and you will tear their arms, which is a big deal because it takes a lot of time for them to heal up, especially if they're diabetic, especially if they're on certain medications. And so do be careful with that, with skin tears and moving these patients. Don't forget what polypharmacy is, taking a whole bunch of medications. When you take a whole bunch of medications, you're bound to have one of those interact with the others. It's very common for an elderly patient to get into trouble with medications. I recently got asked about a patient having black tarry stool. And so when you think about black tarry stool, you immediately think GI bleed. Well, my first question to the person was, are you taking Pepto-Bismol over the counter? And they said, well, yeah, I am. Well, Pepto-Bismol is known for causing black tarry stool. So when you start having all of these medications, sometimes they're calling for these legitimate complaints that are very serious, and it takes a lot of investigation in your sample and OPQRST to conclude, well, this is an expectation of all this medicine. So in that person's case, they did not have a GI bleed. They were taking bismuth, and bismuth is known to cause that black tarry stool. And so the first step would be stop taking that medicine for a couple days and see what happens. They're also more susceptible to depression and suicide. Remember that they outlive a lot of their family. If you get to be 80 years old, 90 years old, there's a good chance you're the only one left. And that's a lot to deal with when you think about who's going to care for me, who's going to make me financially stable if that's not something that's squared away. And for a lot of people, it's not. So as you get older, you get back into, when you're young, you're trying to find your stability, and then your middle age, you're supposed to be stable, and then when you get to your later ages, you are again in that place where, is the money running out? Am I running out of social support, where my family members are dying ahead of me and now I'm left alone? And so that brings me to the Jim's Diamond. The Jim's Diamond is the way we assess and think about the elderly population. And the Jim's Diamond simply stands for geriatric, environmental, medical, and social assessment of the geriatric patient. When we think about the environment, we remember that they get cold a lot. A lot of cold. They're not able to warm themselves. Their skin is very thin. They're also very susceptible to heat. So when you see the news come out and say there's this freeze warning, the news comes out and says there's this heat flash warning, and then they come out and say, well, we're putting up shelters. And you're like, well, what the hell are you putting up shelter for? Every single year, elderly people die simply because there wasn't an appropriate air conditioning parameter, or someone wasn't looking after them. Every year we raise thousands of dollars in funds to put air conditioners in houses, to put box fans in houses, to put heaters that are safe in the elderly population's housing. So this is a big deal, and a lot of them die every year. It would probably be an interesting fact to go and look in Charleston alone last year, and some of the previous, about the 5-year range, how many people we've lost in the elderly population secondary to heat illness or freezing illness. So you got to think about their environment, okay? Look at their environment when you go in their house. Is the clothing correct? Are they clean? Is the environment that they're living in suitable for their age? Do you smell urine? That's a big deal. If you smell urine, then they're not making it to the bathroom in time. That's skin breakdown. That's going to cause sepsis. That's a big deal. We need to let the hospital know, or we need to let social services know if there's no caregiver that we can notify. You got to remember that this is a protected population. The elderly population is protected, which means they are a must report population. We go back to that conversation of EMTs and paramedics are obligated to report when we find populations that are susceptible to abuse and neglect. So if you go into a pediatric house or you go into a geriatric house and there's no food, there's no air conditioning, the lights are turned off, you smell urine, the person's wearing dirty clothes, the stove was left on and something is burning, these are big things that you cannot overlook, and you could be looking at civil legal liabilities if someone could prove that we dropped the ball, that we saw conditions that we didn't report. So you got to think about the environment of the geriatric patient. The medical assessment component of GYMS just talks about all the stuff we've said about their organ function decline, the polypharmacy, the chronic illnesses that they tend to have stacking up against them, even taking into account some of the mental illnesses stacking up against them. And then the S accounts for social. Who's coming to check on them? Are they getting in and out of the house? Do they go to the senior citizen center? Is their activity level appropriate? Who would we call if there's an emergency? Where's the next of kin? Are we in a nursing home? Is the person still living at home? The social dynamic of the geriatric patient needs to be considered also. So the book is going to talk about the GEMS Diamond. You need to know what it stands for: Geriatric Environmental, Medical, and Social Assessment of the Elderly Population. You need to know what the GEMS Diamond is and how to use it. Think about it. When we did peds, we did stable. When we were doing geriatrics, we do GEMS. And so we want that stuff on your brain so that it helps you assess these people. Someone's fallen down and cannot get up. All right, so there's the GEMS Diamond right there. You can do this material. Sample and OP accuracy is going to be a big deal for these patients, guys. So you got to dig into it. It'll help you understand why you're not seeing a tachycardia, why you're not seeing a fever. Okay, we already talked about trauma in geriatric patients. And responding to skilled nursing facilities. Skilled care facility is a cute 2022 way of saying nursing home. We're not allowed to say nursing homes anymore, but it's still something that needs to be said. The skill part is iffy. That should have a question mark. Right about here, there should be a question mark, because we tend to find a lot more worse conditions sometimes at these facilities than we do even when patients are at home. So don't think you don't have to do all the stuff that we normally do because they're coming from a nursing home. Yes, you do. You still need to check everything. You still need to go through the paperwork that they give you. You need to verify what they have said they think is wrong. You need to make sure you agree. Don't take anyone's word for it. You check your own sugar. You check your own vital signs. You do your own assessment of the patient. That's something to think about with the skilled nursing home facilities. Don't forget about MRSA. Make sure you're washing your hands. They're infectious facilities. They tend to have a lot more of these communicable infections just being around each other like that. Clostridium difficile, or C. diff, is that nasty infection that makes you have violent diarrhea, and it is not able to be killed with alcohol sanitizers. That's why you must wash your hands. You will catch C. diff if you keep using sanitizers only and not thinking about washing your hands. C. diff is not killed by sanitizer. Make sure you are reporting abuse and neglect if you find it. Make sure you remember that on the inner thighs there should be no wounds because that's a protected space. Why the hell would there be inner thigh wounds? So if you see wounds that aren't compatible with falling down or aren't compatible with an elderly person just, being elderly, then you got to wonder about that. We don't normally see bruising of multiple stages of healing on the inside of the thighs, and so that's a big deal. Even if you're seeing it on the inside of the forearms, that might concern me that those are defense wounds. When someone goes to strike you, you put up your arms and you try to keep them from striking you. Well, what faces the striker? Your forearm. So seeing a bunch of forearm bruises on the inside of the arms, on the inside of the thighs, that would worry me. It would make me think about abuse. Again, they're more common to neglect than they are abuse, but you got to watch. People will abuse the elderly because it's a stressful population. When you're a grown person trying to take care of an elderly parent or an elderly family member, Sarah, you're fine. Then that can be very stressful and very financially stressful. I'm going to put Sarah Armand in at 1840. Sarah Armand at 1840. Which you're fine because we didn't have any questions before that, so no lecture assignment due for that. So for the following, so we're at minute 42. 42 minutes of the lecture. Tell me that on the lecture assignment. That'll be lecture assignment question number 1. All right, the least common cause of death in patients over 65 is what? Oh, I was wondering why no one had said anything, because I was in the wrong chat. Yeah, drug overdose is not as common. Does it happen? Yes, but stroke, diabetes, and heart attack is very common for elderly people. According to Jim Steinman, a person's daily living is evaluated during what? Yeah, their social ability. A condition that clouds the lens of the eye. A cataract. Why would she have burned her hand like that? The answer is D. You got to think. They're talking about an elderly woman. We've discussed extensively that they lose their sensation. They have neuropathy. So, because they have a delayed pain response, it furthers the injury. So, D. Slow onset of disorientation. So, this is slow, not acute. Which one would that be? Delirium or dementia? Dementia. 71-year-old, history of hypertension, vascular disease, low blood pressure, fast heart rate, fast breathing, abdomen is rigid and distended. Low blood pressure, fast heart rate. He's elderly with high blood pressure and vascular disease. It's screaming at you. I'm going with aortic aneurysm. Okay. Vascular disease and high blood pressure. The longer you sit with high blood pressure, the more likely you are to make an aneurysm in your aorta, which will eventually kill you. So this person has tearing abdominal pain. We've discussed that a lot. Tearing abdominal pain, anything that's tearing, that is always going to be a sign of vascular pain. So I'm going with aortic aneurysm. And it is. He has the classic history, high blood pressure and vascular disease. So this would be a dissecting aortic aneurysm because the blood pressure is really low and the heart rate is high. So he's actually dissecting, which means he's emergent. Which of the following is a physiological change that occurs during aging? Which one of these is true? Are you guys reading the same questions I'm reading? Correct. The decline in kidney function is correct. We do not increase in the size of the brain. We would actually decrease, if anything, we would decrease. Blood pressure gets higher, tends to be, and alveoli lose elasticity, therefore they don't oxygenate as well. So kidney function declining is true. Which of the following conditions makes an elderly patient prone to fractures? Osteoporosis. Very good. Polypharmacy is a term used to describe what? Many medications taken every day, yeah. Inflicted bruises are often found in the following areas except inflicted bruises. So I caused the bruise. Yeah, we tend to not find them in the inner thighs because that's a part of you that's protected, right? So it makes sense that they wouldn't be found. The forearms are always found because a person's defensively going to throw their arms up, and so that's where the strike will land. So inflicted bruises tend to not be found in the inner thighs. The forearms being inflicted bruises are typically found on the buttocks, lower back, genitalia, and inner thighs, cheek or earlobe, upper lip. So, bruises to these areas increase your index of suspicion. I just don't agree with them, except that you're talking about a patient who can't take care of themselves, and so then they can't fight back. Um, I don't really know what their thinking is here because it's normal to defend by throwing up your arms, but maybe they're just saying they're so old that they can't. I don't know. That's reading in. I hate that question. But just remember their answer. Their answer is the forearms. Inflicted bruises are not commonly found per them in the forearms. That's just weird. It's not common to find. If I found bruising on the inner thighs, I would suspect sexual assault, most likely, because that's a protected area. All right, take that for what it's worth, and it ain't worth much. 37 special challenges. Let's take a 5-minute break. We'll come back at 7 p.m.
You are now muted.
Okay. All right, now we're back on.
You are now unmuted.
Okay, everyone, welcome back. Can I get some hands up, please? Kiara Lemon, are you back yet? I'll give you a couple more seconds and I'll check on you. Remind me to check on Kiara Lemon. Make sure she's back. Everyone can hear me because you put your hands up, so we'll go ahead with special challenge patients. This is going to cover patients that are on home ventilators. Maybe they're getting tube feedings at home. Whatever their case may be, the best source of information comes from their home caregivers. There's no way to teach EMS personnel about all the different kinds of illnesses that patients have to live with and go home with. So there is a point in which significant illness patients will be discharged from the hospital. It's very costly to keep them in the hospital. So they may go home on ventilators. They may go home on intravenous medications. They may have ports or lines in them that get chemotherapy or dialysis treatments. So this chapter is going to familiarize you with some of the common special challenge patients that we encounter. That's the purpose of it. Some of those will be the homeless, poverty patients, bariatric patients, which are very obese patients, technology dependent like ventilators. So that's who we're talking about. We'll discuss these factors on the slide and go through them a little bit more importantly. Again, no matter what different one I put up on the screen, it's all going to come back to check with the caregivers that are at home. So if we're talking about autism, if we're talking about cerebral palsy, if we're talking about whatever the case may be, you got to talk to that family. If they're calling us, they have gone through whatever it is that they do at home to troubleshoot and mitigate an issue. And now they're calling us. A lot of times they're calling us because we are the mechanism of transport. They would not need us as far as the care goes as much as they need us for our stretcher and our ambulance. They can't get the patient into their own vehicle. So a lot of the times that's the case with these particular patients. So I'll let you read through the different ones of them. With autism, I will just say be careful with noises and be careful with being too aggressive. You got to figure out what works for this particular person. Autism is a very important issue where they do not interpret stimuli the same as you and I. Typically, they're very intelligent, they are very capable, but they can't get all of that intelligence and capability out into spoken words. And so there's a lot of frustration that goes along with them trying to communicate with us. And so that's got to be pretty incredible to think about, to be kind of stuck in your head and not able to articulate to the outside world what you mean, what you intend, what you need. And so because of that, you can have a lot of violent outbursts. You can get into a situation where they need to be restrained. I would offer to you that there are some people out there that have the touch, that know how to communicate and be patient and work with these normally kids, but they can be adults. So read about autism. It's very special, I think. And I think we also do it wrong a lot, and we don't reach some of these patients the way that we could if we had more training. And we have to sedate them and restrain them when we should be able to learn to communicate with them a little bit better. Not always plausible, but we should try. Down syndrome, I just want to tell you their tongue is bigger. They're harder to manage for airways. Their head is a little bit bigger. You're going to see test questions about that. So big floppy tongues, flat occiput. The back of their head's big and round, but it's flat, so it's not as good of holding an open airway. It's not as good for BVM ventilations, and so it makes it a little more difficult to manage their airway. So think about that. Obviously, we want to build a rapport with these challenging patients. Think about Down syndrome. By the way, Down syndrome can, again, be a very progressive patient who lives on their own, who has a job. You can assume nothing. Just because they have autism, just because they have schizophrenia, just because they have Down syndrome, none of those things mean that they won't lead a somewhat normal therapeutic life. So you can't assume, okay? There are highly functioning people that fit in these categories. So think about that. I'll let you read about the visual impairment. I'm just going through to the ones that I know you need to be paying attention to. I do not like this from the book. This can go bad very quickly. It has gone bad many times and made its way onto the news. If you are not confident in your Spanish, in your Mandarin, in your sign language, do not try to wing it. It is very disrespectful, number one. And number two, it can get you in a lot of trouble. So there have been many public service agencies that have been blasted on the news, and people have resigned secondary to trying to give it their best shot. Do not do that. So read this for what it's worth, but do tread lightly here. Anytime you encounter a patient who speaks a different language, we have something called the language line. You can call the dispatch center and say, connect me with the language line. I need a Spanish speaker. I need a Mandarin speaker. I need Arabic. Whatever it is that you need, there are paid people sitting on the phone waiting to try to help you, to try to communicate with that patient. That's called the language line. It's very helpful. I've used it many times in my career, and it always brings an enormous calm to the scene, and you get the information that you need. So that's out there. Don't shout at people, figure out what they need, and then go from there. Cerebral palsy, you're going to get a lot of questions that simply ask you, what is this disorder? And so when you see a disorder in this chapter, make sure you make enough notes, study enough to know just a little bit about that disorder, okay? So cerebral palsy is typically encountered during birth, and we think it's because the head gets engaged into the birth canal and we can't get the baby out fast enough, or they don't progress, and so then there's some type of anoxic injury where the brain went too long without oxygen, and that results in a multitude of symptoms in the patient. So they could be pretty higher functioning CP, and then they could be debilitated, even don't survive past 3 to 5 years of age CP. So CP is variant. It's not the same for everyone. I know many cerebral palsy patients that you would not know are CP patients. They have had so much occupational therapy, physical therapy, language skills therapy, and they have been able to heal and become productive through their CP. And so, again, assume nothing. On the other end of that fence, you could find a CP kid that is nonverbal and kind of in a vegetative state. It depends how much oxygen deprivation they encountered. Not uncommon to be in a wheelchair, not uncommon to have leg braces, not uncommon to have developmental delay in speech and communication. Spina bifida is kind of easier. It's pretty debilitating. They don't tend to survive long if it is significant, although there is some surgical repair and capability in the United States and abroad. But basically, the spinal cord or parts of it are exposed at birth. Paralysis, don't forget that they like to help themselves. They want to move themselves over, but if they can't, if they don't, if they won't, then you do it. But they might be in automatic wheelchairs. Don't forget to bring these things. If they have walkers, or if they have a foldable wheelchair, or if they have something that they use to as an activity of daily living in every aspect, you need to bring that stuff with you. Don't leave their walker behind. Don't leave their cane behind. Don't leave their foldable wheelchair behind. You might need that stuff. Urinary catheters. It's very rare for people to go home with urinary catheters nowadays because of the risk of infection. But if they do have them, please be very, very careful. There is a balloon inside the urethra that keeps a urinary catheter in place. if you yank that urinary catheter out, that balloon has to rip through the urethra, and that's just really painful to think about, and it could potentially cause trauma injury that lasts some time for the patient. So be careful with urinary catheters getting stepped on, or if you're moving from one bed to another bed, make sure that urinary catheter is accounted for. We call this walk-arounds. So when you go to move a patient from bed 1 to bed 2, we all do a walk-around. Make sure you have everything you need in the place that you need it before you count to 3 and move that patient over. Because once it's done, it's done. That might be IV lines, that might be the endotracheal tube or the king tube, that might be a urinary catheter. Before we move people, make sure we're not about to catch something or drop something or injure the patient in some way because of the movement. Remember that the person at the head always does the count, and on 3 we go. The person at the head should not count until they have made sure every single person assisting agrees they're ready. You don't want the person at the legs trying to grab a catheter real quick and pull it on top of the bed, and then everyone just goes and the catheter gets yanked out. So think about that. Tracheostomies, you've heard a lot about that in the airway chapter. You know that that's where we have a tube directly into the trachea that helps the patient breathe. These tend to be good for us because we can oxygenate them, we can ventilate them. They're direct tubes to the lungs, which is easier than trying to maintain a mask seal with a BVM. So there's that. But they do often get clogged with mucus, and so that becomes a little bit of a problem. So you might have to troubleshoot that, and the family knows how to troubleshoot that as well. Remember that you cannot put soft tip suction down a tracheostomy. That's called a sterile suction technique. You cannot put soft tip suction down a tracheostomy. That is an ALS skill. But the family can, and a little bit of normal saline will loosen up mucus and allow the family to suction that tracheostomy a little bit. Now, I would argue they've probably done that before they called you, but if they haven't, then that's a potential thing that you could have them do. You are able to suction around the tracheostomy, but you cannot suction inside the tracheostomy. So just keep that in mind. Colostomy bags are when we can't let people poop the right way, so we have to make them a stoma that comes out of their belly. I would say there's two folds of a thing here. One is don't let seatbelts and other things catch these things and rip them off. That's really horrible, like extremely horrible. Not only is it bad for you and there's a big mess to clean up, it's very embarrassing for the patient, and there's no going back. Once you do something like that, the call is horrible from that moment on. So you gotta be careful of what you're doing with people with the seat belts and moving people across the stretcher and not paying attention to what could be underneath their clothes. Colostomy bags are a big deal. Check for them. They're not something people are going to tell you about very often because they're embarrassed of it. It is one of those, things that people don't really want to tell a lot of folks. And so you got to be careful with that. Okay? Don't yank those things. Feeding tubes, you'll see these, especially on kids, and they'll have a little feeding tube sticking out of their tummy that goes into a portion of their large or lower intestines, depending on the situation. Be careful not to pull these out. Make sure that they are secure with some tape. If they come out, if that's the reason you got called, we do not put them back in on a typical basis. You may work somewhere that does put them back in, but you'll have a very specific training program on that, and you'll put them back in based on your guidelines. The general, 911 service does not put all the effort that needs to be put into replacing feeding tubes. So this is a patient you would take to the hospital. They'll get that feeding tube replaced in the emergency room, most commonly, and they'll go back home. But families will often call us and ask us to replace them. We do not replace feeding tubes in this area. None that I know of. I'll let you read about obesity patients. We already know about tracheostomies. I'll let you read about that again. There's an example of one. Don't forget there's a balloon on the end of that thing. And it needs to have some suctioning because of that mucus. So get family to help you in that regard. don't be afraid of tracheostomies. You can put your BVM on that. That's the standard adapter for BVM. You can also put a non-rebreather mask over it and oxygenate the patient. They can breathe. What to do if we have trouble with a tracheostomy? This is the DOPE mnemonic. The DOPE mnemonic covers not only tracheostomies, but also your king tube. The equipment failure side, we typically check the equipment before we place it, right? So there's that. Keep going there for the same thing. So the equipment failure part we've typically checked before we put it in. Displacement, we're supposed to be monitoring with capnography and capnometry, right? So we would know immediately if it was displaced or dislodged because we would lose our square waves and we would lose our metric value of 35 to 45. So that one should be pretty obvious. And then listening to lung sounds will help too. Obstruction of the tube, that's your mucus typically. And then pneumothorax, that's because if you have a direct route to the lungs, which is shorter than what your normal breathing route is, it might cause a pneumothorax to be overventilated. BVMs, bag valve mask ventilations, if you are squeezing too hard but you have a good seal, you can collapse a lung and that would cause a pneumothorax. And so you would be absent in breath sounds on one side or the other, and that would be an acute change. Earlier, you had good bilateral lung sounds, and now you just have lung sounds on one side. So do remember DOPE mnemonic. It's really important, not only for you, but also for your paramedic. The DOPE mnemonic helps us troubleshoot any airway device, whether that's a king tube, an intubation, a tracheostomy, even ventilators, because the ventilator needs to be checked too. Is it on? Is it displaced? Has it come off of the endotracheal tube? Has it come off of the tracheostomy? Do you have a pneumo now? Because we're artificially ventilating the patient, so it makes sense that we might have we might have been too much on the pressure, we might have been too much on the volume. So know how to go through DOPE. If I were to ask you, how do you troubleshoot a tracheostomy problem? How do you troubleshoot a ventilator problem? How do you troubleshoot a king tube problem? The answer is DOPE. Okay? You should know that the top one is your lung sounds, it's your chest rise, it's your capnography and capnometry. This one, obstruction, is mucus. Potentially you have kinked it. Maybe the ventilator's tubing is there's a medical bag on top of the tubing, something like that. Pneumothorax, you have unilateral lung sounds. So do we have lung sounds on one side but not the other? That would be a big deal. And then equipment failure, did the balloon fail? Is the device, somehow not able to be remedied? I'll let you read about home oxygenators. For mechanical ventilators, do not be fearful. Do not be fearful. You'll try to help the patient troubleshoot a mechanical ventilator problem. And if you can't, move to a bag valve mask, period. If they can't ventilate on their own because maybe they have a spinal cord injury, maybe they have a phrenic nerve damage, for whatever reason, they're not breathing on their own, they're on a home ventilator. If you can't figure out what's wrong with this ventilator, they're not getting enough air, then ventilate them with a BVM. That is the number one emergency solution to a ventilator. If the machine isn't working right and you aren't smart enough to fix it, which is fine because we can't know every type of ventilator out there, then move to a bag valve mask. Take your mask off and connect the bag valve mask thing, the little connector, the standard adapter, to the end of the trachea tube, to the end of the endotracheal tube, whatever their case may be. Okay? So don't let mechanical ventilators scare you. If they're on something like this, bring it with you. If the patient has a nighttime BiPAP CPAP device and you can bring it, bring it. If the patient has a home ventilator, bring it. Bring extra batteries. Don't get so caught up in the situation that you forget that the hospital does not typically have the same systems that the patient goes home with. And so, yes, we can figure it out, but it would have been much better if we could have brought the patient's device that their body is used to the hospital. They're going to be more comfortable if that's the case. Internal pacemakers cannot shock you. I just want to say that. So, don't be afraid of them. Try not to place defibrillation pads from our own AEDs directly over the device. We should go around it if at all possible. Remember that internal pacemakers have a big old hump in the skin. Just go around the hump, okay? Remember that you can still use an AED on a patient who has a defibrillator implanted. If it was working, then the patient would be alive. So keep that in mind. Now, you're eventually going to go to a patient who is being shocked by their internal pacemaker or their internal defibrillator. That's not uncommon. Just get the patient, put them on oxygen, get them on all your vital signs equipment. Remember that it can't shock you. It's directly into the tissue of the heart, and emergently transport the patient. Don't freak out. It's easy to freak out because it's scary watching the patient get, jolted by this thing. And they describe it as being kicked in the chest by a horse. So the patient hates it. And so just be calm, be confident, put on your monitoring equipment, put on the oxygen, get the patient on some oxygen, and get out of there as, safely and calmly as possible and emergently transport the patient. ALS backup would be best because we can give the patient some medications that will stop the heart rhythm that's causing the device to fire. If there's any questions about that, let me know. Left ventricular assist devices. I'm hoping there's some pictures in your book. I'm not sure if there are. I won't talk a lot about this because it's a training point that's going to occur when you get hired on as a job. So when you go work somewhere, say Charleston County, they're going to do classes on LVADs. That's what that's called, LVAD, left ventricular assist device. But basically, this patient's heart is so sick it's not pumping on its own. So then we put a little pump into the left ventricular assisting, and it gets all the blood to the good parts. Here's the problem. Some of them don't generate pulses, so you may lose the normal assessment features that you would use on any other patient. Some things to remember. You can't typically do CPR on a left ventricular assist device because it would rip the pump out. Some things to remember. Put them on end-tidal CO2 because if you have end-tidal CO2, you have a blood pressure and you have heart function. So people forget that. Well, the blood pressure's not reading and I can't check a pulse. Well, get them on end-tidal CO2. If they're alert or conscious and they're breathing, get them on end-tidal CO2 because if your end-tidal CO2 is between 35 and 45 or something near that, above 20, then you've got a blood pressure because you couldn't be exchanging oxygen and carbon dioxide without perfusion. So in order to do that, you've got to have pulmonary bed perfusion. And measuring end-tidal CO2 is great for these patients. Don't forget to check a sugar on these patients. That might be why they're not conscious. Also, volume is a big problem for them, so you need to call ALS backup. They tend to run into hypovolemia, dehydration. You can imagine that any kind of pump doesn't pump well if it doesn't have enough fluid running through it. So if the patient gets dehydrated, that's going to be a problem. Here's what I want you to remember about left ventricular assist devices the most. It has a phone number on the device. If you find some weird device you've never seen before and you're like, oh God, what do I do? I don't know anything about this. There is almost always, in those cases, a telephone line that is manned with medical professionals who know how to help you treat that patient. Okay, so call that number. And you can always take your stethoscope and listen over the heart and hear the pump running. If the pump is running, then that's a good thing, that's something good. And then try to assess the patient the best that you can. But they don't typically generate pulses, which makes sense because it's a pump instead of a contraction. And they can be unconscious, and you have to really figure out why. You can still defibrillate these patients. And so if they are unconscious and they're not breathing and you believe that they are in cardiac arrest, you can put your AED on the patient. And if shock is advised, the patient is unconscious, they're not breathing, then you can shock this patient. Because if their heart goes into a bad arrhythmia, then they even more so do not have blood coming out of the left ventricle, and so the device may fail. If you shock the heart, it may go back to some amount of perfusion that lets the assist device do its job. This is a big topic. Certainly one slide and a little bit of talk in a chapter is not going to do it. These are rare. They're not common in the field. They are out there. We do see them. We're familiar with them. Every year you're going to train on them. But this is way more of an ALS thing than it is a BLS thing. However, if you're on a BLS truck and you're the closest unit to something, then you are. And so you might see it. If you do, don't be afraid to call the number. Don't be afraid to get the family to help you. This entire chapter is focused on you utilizing the people who care for these special patients at home. All right, central lines. So we put central lines in people who need emergent medications or dialysis, and sometimes they go home with them. So when we put dialysis shunts in people's arms and legs, that shunt takes somewhere around 3 to 6 months, even sometimes longer, to become healthy enough for the patient to be dialyzed using that shunt. So you might find a patient who has a central line put in because they haven't made it to the point where that shunt can be used. So central lines are pretty dangerous to be in the field because they're literally a tube going into your subclavian vessels. And if they get ripped out, then that can be a pretty significant bleeding scenario. My advice to you is direct pressure, direct pressure, direct pressure. If you run into any type of situation where this is bleeding really badly, direct pressure over that space, and that needs to be as much pressure as you can put. So the biggest things about them is you want to see that the dressing is in place. You want to see that it is dry and it looks clean. The most common complication with filled central lines is infection, because we're literally opening up your subclavian vessels to the external environment. That's pretty dangerous, and we only do this for patients where there aren't many other options. And so if you see a central line out there, number one, leave it alone. Number two, is the dressing dry and intact? Is it clean? And so most patients won't need you to mess with it or do anything with it. They just happen to have one. Your paramedics can access these in emergencies, and so you might see us accessing them, but otherwise you really won't encounter them much. Just keep them safe. Don't let the harnesses of the seatbelts on the stretcher, get this thing pulled out. So you got to pay attention to what you're doing. Patients have feeding tubes, they have colostomy bags, they have central lines, they have ports underneath their skin. Don't let our equipment and our environment damage these special things. This is common in chemo patients. It's common in dialysis patients. It's common in patients who are receiving a lot of blood products because of, one condition or another. So you're going to see these. The patients hopefully have told you that they have one so that you can at least be aware of it. But that's why a good sample and a good OPQRST is really important, so that you can ask questions that make the patient, stimulate the patient to tell you they have these things. Okay? I already talked about the G tubes, so I'll let you read about that. Shunts, remember that we put shunts in kids' ears that tend to have chronic ear infections or maybe hydrocephaly, where they have water on the brain when they're born. So basically, we're trying to drain excess cerebral spinal fluid. We're trying to drain water on the brain, quote, quote. We're trying to assist with drainage because they keep setting up infectious process. These tubes tend to drain into the peritoneal space, and so there's that. The device is beneath the skin on the side of the head, behind the ear, not super visible to you. The deal with shunts is, if a patient who we know has ventricular peritoneal shunts, we need to be on the lookout for severe acute headache, severe acute altered mental status, and severe fever. That tends to indicate the shunt is blocked. It can cause seizures. It can cause some significant neurological presentations in the patients. So if a person has ear shunts, ear tubes, head tubes, whatever the family calls it, and they will be creative, trust me. That's what you're looking for. Let's maintain airway. Let's get some oxygen on board. Let's check a fever, a temperature. Let's check a sugar. Make sure that's not the case. These chapters start getting into the scary parts of our job, guys. And you won't have to be scared if you remember to check every single vital sign I told you. When you get into patients like this, if you miss one thing, that's probably going to be the thing. You got to check temperatures. You got to check BGLs on every emergent patient. If you're worried about this patient being actually sick, then all of the vitals get done. Okay? Don't let stuff sneak up on you. Don't get to the hospital and find out that the patient has 104 fever and you didn't know. Okay? That looks poorly upon you, and you're better than that. And there you go. So nausea, vomiting, seizures, irritability, headache is a big one. Super common. In babies, they're what we call unconsolable, inconsolable. They're just crying nonstop, day and night. Anytime you get a kid that just does not stop crying, something is wrong. They are sick. We need to be persistent about going to the hospital. I talked about colostomies. I'll let you read it. DNRs, remember that there are people who are going to die in our presence and we're going to do nothing because they have a DNR. And that is what we should do. Nothing, because we want to respect them. And when I say nothing, I just mean we're not going to try to resuscitate them. You can always put on oxygen. You can always suction people's airways to keep their airway clear. Don't let people, gurgle on secretions. That's not okay. You are more than within your right to give oxygen, to give suctioning, to provide blankets and comfort measures. When you see a DNR, don't think that means, okay, hands off, we do nothing. That's not true. DNR means don't do CPR. So if it's not CPR, you can do it. Medics constantly get this wrong. Well, they've got a DNR. That does not mean we can't assess the patient. It doesn't mean we can't provide comfort measures, blankets, oxygen, suctioning, transport because the family is uneasy with the patient dying at home. Let's do our jobs. We're there to heal people, even if those people we're trying to heal are on their way out of this world. And that might be their family too. Just because they have a DNR doesn't mean our job stops and it no longer exists. We still have things we can do to bring comfort to our patients. Get a little look at that, read that a little bit. You're going to encounter some hospice nurse patients. They're not supposed to call EMS. They get told that when they go on hospice, but they do a lot. They call us a lot because the family freaks out. And no matter how much you've prepared for the end of this thing, it's hard to watch and it gets scary and there are noises and the patient starts, doing what feels like suffering. And so they dial 911. And so that can be jolting. It can be scary. You need to honor the DNR. You need to provide blankets. You need to provide oxygen, get some suctioning, comfort the family and interact with the hospice nurse. There's going to be a hospice nurse there. They're the specialists. They are the people that do this the most often. Let's back them up. What do you need from us? What can we help you with? What can we provide for you? I'll let you read about the homeless, which we deal with a lot, which is something we should deal with a lot. I do want to say this real quick. If empathy is not your thing, get out of this job. Don't go on. Don't become a doctor. Don't become a PA. We serve the most helpless, lazy, don't want to work, don't want to take their medicines. They don't want to heal themselves. They want us to fix it all in one day when they're not doing anything to fix it at all. They don't want to do anything for themselves. That's who we serve. And if you can't do that, if you can't lift up these people that maybe don't even deserve it, then this is not the job for you. Because I'd say 80% of this job is serving people who probably don't have an emergency, who don't need an ambulance, who don't need an emergency room, but there's nothing else for them. For whatever reason, a lot of times from their own decision making, this is all that they have left. Well, that's what we do. And if you can't do that, maybe this isn't the job for you. And it ain't always easy. I won't pretend that it is, but it is what we're here to do. So I ask you, train your mind. Train your mind to understand and to acknowledge and to accept that a lot of the patient population in the emergency environment is not emergent. We need to stop griping about that and do our jobs. If they want to go to the hospital, they get to go to the hospital. If they want to go to this particular hospital because it has Doritos, if it's within your policy, then they go to that hospital because it has Doritos. Give them blankets. Be nice to them. It's not difficult to be nice to someone for 20 minutes. And that's about how long we have them. So, there's that. It is tough. We do see the same frickin' people. We know their names, we know their demographics, and that's great. Develop a rapport. You can make it easy or you can make it hard. You've got them for 20 minutes. Why not make it easy? Talk to them. How's their day? What are they doing? What's new for them? It's not that hard. Give people your time. Which of the following is a developmental disorder characterized by social interaction impairment? And the answer is autism. I told you, they're in there. And they're normally very smart and very intelligent and very capable and very high functioning, but they can't communicate well with us. Okay? So I have a bleeding heart for that because maybe we're not smart enough. Maybe it's us that's the problem and not them. There's a huge documentary on Netflix for autism about being trapped inside, and it's an incredible thing to watch if you ever get a chance to look at the Netflix. They did a signature series on autism, and it's really, really incredible. And it helps you understand that these patients are able, they do know, they do realize what's going on around them. They can't interact with you, and that's frustrating. So think about that when you address these patients.
What's the show called?
I don't remember the exact name, but I guarantee in about a 5-minute Google search you could pull it up. Well, it's good enough that I'll actually try it right now. It is. I'm gonna research that for you, and I'm gonna get back to you. I recently watched it again. I've watched it a couple times. It's incredible. Let me. There's a couple of options here. None of them ring a bell, so I'm not going to quote those. Let me look it up for you, and I will send it out so that you guys can watch it if you want. And it's not long and horrible. It's pretty incredible. So, known risk factors for Down syndrome include. This is straight from the reading material. And basically, the big one is increased maternal age, which is past 42 weeks. Which of the following may be difficult to perform on a patient with Down syndrome? We talked about this. Yeah, any airway thing is going to be a little difficult. That rounder head, flatter occiput, big old tongue. And again, these aren't always the case, but it's something we think about. Most patients with this disease have hydrocephalus, water on the brain. Talked about this a little bit, and the answer is C, spina bifida. You're talking about the brain, you're talking about the neurological system. So hydrocephalus and spina bifida do go together, and you can have hydrocephalus for other things, but that's common. What does dope mnemonic help you recognize? Dope mnemonic, what does it help you do? Displacement, obstruction, pneumothorax, equipment failure. It helps us look for airway obstructions, yeah. And particularly in this chapter, they were using it to discuss tracheostomies. What device is placed directly into the stomach to feed patients? A gastrostomy tube, right? A G tube. G for gastric. What do vagal nerve stimulators do? And the answer is D, because anytime you have an all the above or a multiple answer scenario, that's probably the right one. So vagal nerve stimulators do keep seizures from occurring. That's their goal. And then C, act as an alternative treatment to medicine beyond pharmaceuticals. So both A and C are correct. The way this works is the vagus nerve is supposed to be the reset button, right? And so if there's too much stimulus, then hit the reset button. And that's what these vagal nerve stimulators attempt to do. So you're talking about patients who keep having seizures even after multiple pharmaceutical therapies have been approached. An important part of the assessment process for special needs children or patients in general is to what? No. What did we say was the whole point of this chapter from the book's perspective? Caregivers, caregivers, caregivers. The people who take care of this person every day are going to be most familiar with their process, their problem, their devices, their challenges. Now, Jason, I totally do respect your answer because we should always, if a person is conscious and alert and oriented, we should always attempt to interact with them. Guys, one of the most disrespectful things, and one of the things that will get you in the most called out trouble on scene, is talking around a patient. Do not ever get into a predicament where you're talking about a patient to everyone around them, but not them. Let a patient talk for themselves if they are able to do that. It's very disrespectful. So B is a good answer, but the particular chapter that we're in wants you guys to know that there's no way to teach you all of this. You've got to rely heavily on the caregivers who have been taught by the referring hospitals before they go home. They teach them how to use that G tube. They teach them how to replace that colostomy and take care of it and maintain it. They teach them how to use that home ventilator. So they're going to be the resource. What improves a patient's quality of life shortly before death? And this is something we talk specifically about. And be global. The bigger answer is the better answer. Anybody? Anybody? I'm going to go with C because C talks about all the potential palliative care options. You remember that palliative means to make it better. We think about OPQRST, we have provocation, provoking is worsen, and palliation, to palliate is to feel better, to make better. And so palliative care is hospice care, it's comfort care, it's end of life care. There are many names for comfort care, but they all fall under comfort care, whether it's called hospice, whether it's called palliative care, whether it's called end of life care. They all fall under comfort care, and so that's why I'm going with C. Hospice is just one version. The the EMTALA Act, you would have read this. This is a big deal, guys. So I would love for you to really take a look at EMTALA. It's going to play a big role in your job, especially if you do interfacility transport. If you go to work for a private company or even a 911 company that does hospital to hospital transfers, you are going to be dealing with the EMTALA Act a lot. And I'll tell you, doctors abuse, misuse, mistreat, and violate the EMTALA a lot. And you don't want to be a victim of their intentional disregard for federal law. So you need to familiarize yourself at least a little bit with EMTALA, which says that people are required to be stabilized for emergencies in this country, regardless of their ability to pay. This is also true for pregnancy. If you are in active labor, we have to help you, even if you cannot pay. So that's EMTALA. EMTALA also covers transfers from one facility that's less capable to a higher facility that's more capable, even if you can't pay. So having that in mind, which one of these things? Yeah. So B is the biggest principle of EMTALA. I would encourage you to go take a look at some things that apply from EMTALA closely to EMS. Okay. One of those things that I want to tell you about is that doctors are not allowed to transfer the patient from their hospital if they have not reasonably stabilized the patient. When doctors get in the weeds, they want you to just take the patient. You can't take an almost dead patient out of a hospital. The patient is in worse condition to be in the back of an ambulance than they would ever be, even if that ER that they are being transferred from isn't very capable, because certainly the ERs are regulated at a higher minimum than the ambulance. And so don't let doctors force you to take super unstable patients out of a perfectly good hospital. Okay. I'm thinking about patients who need blood. Well, you don't have blood. I'm thinking about you being an EMT truck and the patient doesn't have an airway. Well, you need an airway. They've got to provide that stuff for you. Okay. So EMTALA covers some of that, and you'll learn more about that when you go to work for some of these facilities that do hospital to hospital transfers. All right. It's 7:47. Let's come back at 8:05. 8:05.
You are now muted. You are now unmuted.
Sorry, I was helping Scott trim the nails of the 90-pound doodle, who was definitely winning. We were not. All right, let's pull up a 38. So we are done with special populations, and we're moving into the transport chapter. We're just going to do the first one of these bad boys, and we'll be out of here. Okay, we'll move through this quickly. I'll tell you what's important and what you need to focus on. Go ahead and give me a hands up, please. Make sure we got everybody that's in the class. You go ahead, it's fine. Where is... Did we lose Kiara Lemon? Kiara Lemon. I'm going to put her out at 7:30. What the hell? Okay. Got those people in there. All right. Gonna lower those hands. I see Sarah Ormond made it back in here. Welcome back, Sarah. All right. Operations is basically how we operate, and it is an entire section of the National Registry exam, computer-based testing. You will have respiratory and cardiac, OB, medical, trauma, operations. Okay? So there'll be this, breathing, shock part, resuscitation part. There will be medical, trauma, operations, and OB. So, with that said, this is an entire section. You need to spend some time on it. And I say that because most of you that are really interested in the medical stuff and the trauma stuff, all that stuff, was kind of easier to pay attention to. This is kind of dry and a little bit, it can be, depending who you are, kind of boring. For the fire people in the class, it's not, because it's got all the hazmat and the disaster stuff. But with that said, it is an entire section of the exam, so I'm giving you your warning. Let's get into it real quick. What do we do? How do we do our jobs? And we do it safely, and we ensure that there is a response component that the public can depend on. That's what this is about. Talking about how we operate on scenes, how we get to the scene. When we call for other resources like helicopters, how do we do that? That's what this chapter is about. Decontamination is in here. Not only that, about infectious diseases, but also about hazard materials. We've talked a little bit about that when it has occurred in the book prior to this, like the brushing off of the powder, and then, then we are allowed to irrigate the patient or to decontaminate the patient with water. But it's going to get a little deeper into that topic. We know that ambulances today are very modern. They're very capable. They're many times staffed to the level of an intensive care unit, depending who you're working with. If you're working for a ground critical care service, you're going to have a nurse, a medic, and you, and that ambulance is going to pretty much have everything you would see in an intensive care or an emergency environment, up to including surgical skills. So, pre-hospital care or inter-hospital care is a pretty diverse and capable response capacity. And you know that so far. You've seen the 911 world, but I do want you to know, and this chapter is going to talk a little bit about, there's a lot more out there than the 911 world. When you think about the helicopter world and what we do, and the fixed wing world and what they do, and the critical care ground world, like the neonatal team that works at my base, there's a lot of stuff to do in the pre-hospital world. So don't think that what you know is all that there is, because there's a lot more. This is a big testing piece. You've got to know the difference between a type 1, type 2, type 3, and a type 4 ambulance. We're going to talk about that. Here's the easiest way to remember it. All ambulances are required to have this Star of Life on it. That's from the National Highway and Traffic Safety Administration, which is who governs us under the Department of Transportation. You remember that back from chapter 1. Okay, so the Star of Life is kind of our thing, and it's what tells the world this is an ambulance in the United States. Okay, here are the options for type 1, type 2, and type 3, and there's even type 4. We'll talk about it. The best way I like to tell you about the types of ambulances is to use a service as your reference. So let me find, okay, they're not going to give me that same picture as before, so that was in a different book. So I have to use this slide here. All right, so the way you best remember this is by using a service reference. Around here, the most common thing that we see is a type 1 ambulance. A type 1 ambulance is like this bad boy up here, A. What makes it a type 1 is that you can take the cab off the back and put it on a brand new truck chassis. So it is reusable in a sense. It is the most common that you would see in Dorchester, Berkeley, Charleston. Now, we're in a very unique time right now where there are multiple types of ambulances in each service. I think about Charleston. Charleston had some supply chain issues and couldn't get their normal Dodge double cab type 1 ambulances, so they ended up going with some type 3s. I think about Dorchester. Dorchester couldn't get enough ambulances, so they went with some type 2s. So the way to remember this is the most common one in this area is the type 1, and that is a box that can be reused on a new truck chassis when the mileage gets too high. A type 2 is the van. Think of all your private services. They tend to use vans. These are some of the most efficient, most cost-effective, gas-powered and diesel-powered out there. They last a long time, and they will do most jobs. They won't do bigger stuff like balloon pumps, ECMO, Impellas, maybe even difficult to RSI in them or to manage significant trauma patients or OB patients. So this isn't for every call, but most of what we do can happen in a type 2 ambulance, and that's why all the private services tend to flock to them. You can have more of these than you can have of these. So then there's that potential there. So this is the van ambulance, and it's the type 2. The type 3 is the oddball that you don't really find a lot around here until Berkeley County started buying them. Now, Berkeley County has a few of these. The difference in type 3 and type 1 is that in the type 3, you throw the whole thing away. There is no disconnecting the box from the chassis. It's all one thing. So when it dies, it's all dead. Okay? So there's the difference. Type 1 is the most common, Mac Daddy, big one that you normally see at Charleston. Type 2 is the van ambulance that you see at private services. And Type 3, we don't really have a lot around here, but the Berkeley County system did buy a couple of these, and they have held up pretty well, I think. So with the Type 3, you throw the whole thing away. You got to know the differences. You're going to see it on test question. This is how we deal with an ambulance response, and you know this from chapter 1. This is kind of a review. At the beginning of our shift, we check off the trucks. We make sure the truck is ready to go for the shift. Then we start taking calls. We get dispatched. We go en route. We arrive on scene. We take care of the patient. We transport the patient. Then when we get to the hospital, we give care turnover. And then it's back to resetting and putting our truck back together, getting the supplies that we used, making sure that the next call goes off without any issues. And of course, we're documenting all of that. So obviously, this is kind of common sense to you now, but in the beginning of talking about this in chapter 1, it wasn't. So I hope you have more of a visual to this now that you've been on ride-alongs. Hey, raise your hand if you've not been on a ride-along. Just out of curiosity, you've not been on a truck yet. Just one person? Let me go look and see that Sarah Moss, 2 people. Is it because you guys and Julia Coates? I'm going to make sure that you're on the schedule real quick. It just reminded me. So I'm just going to double check here. Is it because your rides are coming up and they just haven't occurred yet? Is that what it is? Because that would make me feel a lot better. Sarah Mon's got rides coming. Oh, Sarah, yours are coming up really soon. Julia Coates has rides coming. And who else did I see? Sydney Pritchard. Remember, if you finish your 15 contacts, put a line through your name so that I know you're done. More dates, but we got one. Oh, you got one tomorrow, Sydney Pritchard, at 5 a.m. in the morning. Yucky. But you'll like it. As I said yucky, I was like, oh, she needs me to say that she's fine. You're fine. Go to your ride. So now you have more visual to that, how that works. I'm going to let you go through each phases. You know how to do that. You guys know what's on a truck. You know how to fill the equipment out. I will talk about this because it's going to be on the test a lot. We park 100 feet before or past the crash scene. That's a test question. We park 100 feet before or past the crash scene. You should be 100 feet from the scene because people tend to hit our vehicles and they don't want your vehicle running over the responder, okay? We also park uphill, upwind. Uphill, upwind if it's a hazardous scene. The warning lights stay on, also known as the secondaries. So you turn off your headlights. I'm going to write this. Turn off headlights because they blind people. Turn on secondaries. Your secondaries, if you haven't noticed yet, guys, you have 2 types of lights, primary and secondary. Primary is the ones you use going to the scene. And they are the ones that are like a seizure. They're just flashing everywhere, like all kind of crazy is going on, right? Your secondaries are more like blinkers, except it's the same lights. So the red and white turn into blinker lights. They go on and off, instead of the flashy seizure pattern that you would see going to the call. Why is this important? There is Department of Transportation data to suggest that people are more likely to notice and stay away from secondaries than they are primaries, especially intoxicated people. For whatever reason, and we don't know completely why, intoxicated people tend to crash into primary lights, which are the flashy all over the place, red and whites are crazy going everywhere. That tends to cause them to crash into us. So secondaries are what your lights should be when you get on scene. So some people turn on the 4-way flashers, the hazard lights. Some people turn on what we call cruise lights, which is where you just have one solid stay on pattern, red or white. So you need to know the answer to that. We turn off our headlights so that we don't blind people that are oncoming. And we would prefer that secondaries be on if you're on scene. Always park uphill and upwind from hazardous material. and you need to be 100 feet from the crash, whether that's ahead of it or behind it. Those are test questions. Here is an example. If you'll notice, all of these apparatus have the wheels, they're blocking the roadway, number one. So the crash is between blocking vehicle 1 and blocking vehicle 2. This is the most common way, by the way. The ambulance will go up and ahead of the crash. The fire truck will be behind. The fire truck is attempting to block, because it's bigger, it's more massive, attempting to block traffic from hitting us, okay? And then we'll be in the middle here taking care of the patient. Notice the wheels of the ambulance and the wheels of the fire truck. They are turned in whichever way would steer the vehicle away from the responders should the ambulance be struck. So in the ambulance's case here, we have the wheels turned to the right so that if you were to hit this vehicle, it is in an opposing direction. If someone came from the cross lane traffic and hit the vehicle in the front, it would not steer directly into the responders. The same is true for the fire truck. If they hit that truck from the back, it's going to go straight forward into opposing traffic, but not into the walking responders here. So where you turn your wheels is also really important. All right, that's enough about that. Seatbelts on stretchers. If it's there, it should be used. You cannot justify not using a piece of safety equipment on the ambulance. The first thing attorneys want to know is, does the chart say the patient was restrained by all stretcher restraints? Yes or no? And if you didn't write it, it didn't happen. So if you didn't say you put every seatbelt that comes on that stretcher on the patient, then that's a potential liability. So notice the harness here. The most common thing that we see providers doing is they don't want to use this harness. You have got to use the harness, okay? You can't let patients just be buckled by the middle and feet seatbelts. Why? They tend to fly out of it when we have rollover collisions. Yes, ambulances get in wrecks, and they get in wrecks often. The number one cause of death for EMS responders were traffic-related fatalities, either responding to the incident, transporting to the hospital, or actually being in the roadway and struck by a vehicle. You know the 5-minute and 15-minute rule about reassessment, so I'm not going to deal with that. You know how to restock your truck. You know that you need to turn the patient over to a nurse. That most often is a registered nurse, depending what state you're in. Some states are heavy LPN, so it might be an LPN, but in the state of South Carolina, not going to happen. We turn our patients over to registered nurses if you're talking about an emergent patient, okay? So make sure you get the nurse's signature. You need a first name and a last name and their title, because you need to say, this is who I gave care to. And when I gave it to them, the patient was stable. Here's the deal. It's easier to blame you. So you got to make sure you document how the patient was turned over to the next level of care. So don't forget that that's important. Don't overlook that in your charting. You know all of this stuff. Refueling the vehicle is a big deal. We constantly say that if you're less than 2/3, go ahead and get fuel, because you don't know where this next call is going to take you. Okay, what if you're going from Monk's Corner to MUSC? What if you're going from St. Stephen's? What if you're coming from St. George? You don't know how much fuel you're going to need depending on the severity of the patient or the population of the patient. So we always have a 2/3 rule. Some rules that you constantly hear us saying is, once the oxygen gets to 500, change it. Once the fuel gets to 2/3, consider putting more fuel in. Never ever forget to decontaminate your equipment and your truck. They can track nosocomial infections, which are healthcare acquired infections, back to your ambulance. They can prove that this service is causing healthcare acquired infections. For driving the ambulance, that is going to be a training conducted at the employment. They're going to tend to give you EVOC, emergency vehicle operator courses, CEVO, certified emergency vehicle operated. There's lots of versions. The National Association of EMTs puts on a class as well. That happens when you go work for an employer. But there are some key things that we have to talk about that are going to show up on the test question for you here. Number one, you are responsible for whatever comes of any traffic related event if you're running emergent. The laws in most states clearly go against the EMS providers or law enforcement or firefighters, because here's the defense. If you weren't running emergent, if traffic had been in normal operations, would this have occurred? And because it's difficult to say that it wouldn't have, it tends to err against us. In the state of South Carolina, for example, there is no rule that says we can't travel but so fast over the speed limit. It says we can drive however we want when responding to an emergency with due regard. Due regard is a very broad statement, and it is that way on purpose. The law is set up to say if a person is acting within due regard, there would be no accidents. And so basically, if an accident occurs while you're running emergent in an ambulance or in an SUV or any other emergency labeled vehicle, it's your fault. So I want you to have that in your brain from the beginning. When you get behind the wheel of an emergency vehicle and you turn those red and white lights on and you turn that siren on, you have to remember that if anything occurs, if someone runs out in front of you and you hit them, if a vehicle doesn't stop and you hit them, if you run someone off the road and they go into the ditch and turn their vehicle over and get hurt, if anything happens because of however you're driving that emergency vehicle, it will almost always be your fault. Let me remind you that if someone is seriously injured or killed in a motor vehicle event for which you are found at fault, you don't just get higher insurance rates, you go to jail. They take you to jail if someone gets killed in a vehicle related event. So please take heed to the words due regard. Here are some standard rules that we employ. If the lights are on, the siren is on. That is a known rule. If you turn on the emergency lights, the red and white flashy flashies, the siren must be on. You cannot run one without the other. That's the rule. A lot of people love to run the lights by themselves. If you are driving through a neighborhood with red and white lights activated, but no siren, and a child darts across the street and runs out and you hit them, the first thing they will attempt to evaluate is whether you had on a loud noise device to alert pedestrian and vehicle traffic. If you didn't, you're at fault. Never one without the other. The next big rule: driving emergent is no reason to disregard intersections. If there's a stop sign, you must come to a complete stop. If there is a red light, you must come to a complete stop. You should not ever proceed through an intersection because you think your siren and your lights have given you the right of way. They did not give you the right of way. You will get killed or you will kill someone. The most common area of motor vehicle accidents with an emergent vehicle is an intersection. That's a test question. The most common emergent happening, motor vehicle-y speaking, with an emergent vehicle is at an intersection. You must come to a complete stop. The next big rule is about your speed. Most places say you shouldn't be on a regular basis going more than 10 miles per hour over the speed limit. In South Carolina, we don't really have that rule, but the agencies that you work at can set their own rules. So pay attention to that. It's 2022. We have all kinds of satellite equipment on the ambulances. And there is a system in many different apps that we use that will alert supervisors if your ambulance goes a certain amount of speed over the speed limits, if your ambulance hard brakes, if your ambulance encounters more than 4 Gs of force on the ambulance, so basically you're driving erratically, it will send a text message to your supervisors. In some agencies, you even have to use a fob to tell the truck who's driving. Hold on just a second. Scott's forgetting that we're lecturing and he's making drum noises with the yogurt box. Scott, say hi to the class. All right. Now that he's gotten the attention he needed, now he's making a point. All right. So, pay attention to these rules because they'll get you in big trouble. Don't you dare touch your phone in the driver's seat of that vehicle. That's a big thing right now. One of the fastest ways to get fired from an ambulance agency is to pick your damn phone up while you're behind the wheel of that ambulance. It's a big deal. So be very careful with that. Most trucks have two-way cameras in them. They're watching the driver and the passenger, and they're watching the traffic in front of the vehicle. So just be careful, guys, okay? It's out there. We're watching, and we want to know if you're safe. Seatbelts at all times. Let's see what else we can see. Of course, give people room. By the way, guys, people do not hear us until we're really close to them. That siren might sound loud to you. It's not loud enough. People's cars are more engineered to be comfortable and silent, and that presents a pretty big challenge for EMS. They don't hear our sirens. Now, we do have this new device called a rumbler, and that is getting us a lot better response. So having a rumbler is helpful, especially at intersections. But if you don't have rumblers on your ambulances, rumblers, by the way, is using sound waves to create vibration. And so it turns your siren into a physical thing instead of just a noise thing. You can actually feel it in your car, so it's not just being heard. It'll shake the car a little bit, which can be kind of scary. But it's pretty helpful, especially at intersections, because it makes people start scanning their mirrors. What is that? What am I feeling? So if you have rumblers, great. If you don't, you need to know that they don't hear you, okay? They do not hear you until you're right up on them. You're going to see test questions that ask you how much speed is necessary to cause the ambulance to hydroplane, and the answer is almost nothing. I think the answer is greater than 35 miles per hour, the ambulance can hydroplane, which is a very low speed. So the point that it's wanting to make here is that when you get a bigger vehicle that's got bigger tires and a lot more weight, low speeds can cause that thing to lose control in wet conditions. Escorts are going to be talked about a lot. Escorting is when you have law enforcement or other personnel from your agency block off intersections so that you could just fly through them. It doesn't work. It gets people killed. Do not accept an escort. Sometimes escorts happen spontaneously. And due to the acuity of the call, maybe it's a child, maybe it's a fellow firefighter, EMS, or police officer that's injured, they'll provide you an escort even without you having asked for it. So here's my caution to you. Great. However, stop anyways. When you get to the intersections, if there's someone blocking that intersection, that's great. Thank you for the extra support. But it is no reason to blow through an intersection. The other people on the road are crazy. If you have not noticed, they are crazy. My partner at work, Kent Wolf, I'll have to give him credit for this because he would have demanded that I gave him credit. He has one rule in our job, and I can't say the exact language, but he says those MFSs are trying to kill us. That is the number one rule of our job. And he is absolutely right. When we are doing our job, the general public doesn't know there's an emergency. They don't know what's going on around them. They're not paying any attention. And they will literally drive right in front of you every single time. Or my personal favorite is when you get close to someone with lights and sirens and they just lock the brakes up and you about destroy their vehicle, right? They're supposed to gently slow and pull to the right. That's what the law says. But people have not read that book in a couple years, I assure you. They will lock those brakes up right in front of you and kill everybody. So please, guys, be careful. Give people room. If you feel like you're white knuckling the steering wheel and your butt's clenched and you're rigid, you need to slow down and you need to relax. Okay, driving emergent is fun. It's invigorating. It gets your adrenaline going. It's also very deadly. It is very deadly to run emergent. So please, please, please be careful. When you encounter a school bus or a school, just turn the damn lights off because you have no business, no right, no legal provision allows you to forego a school zone, a school bus stop. You might as well just turn your stuff off and stop too. You cannot blow through. That is just too much of a variable and an uncontrolled dynamic. You're going to kill a kid, and no one recovers from that. Not that one should. So don't think that your lights and sirens give you permission to behave, crazy, because they don't.
Justin, I have a question.
Yes, ma'am.
So you said that legally, according to the law, people have to like slow down and pull to the right when you're going through, but
They do. The law requires that.
there's no law that says that ambulances can't like not blow through, but they can't like go through an intersection if there's like different like.
Oh, the law says you can, Druvy. I said that the
Oh,
South Carolina
okay.
law says that Druvy can do whatever she thinks she needs to do as long as she's got those lights and sirens on. Within
Okay.
due regard. Here's the thing, though. Can anyone ever defend that going through an intersection at 50 miles an hour with a red light was due regard? No, you'll never be able to defend that. No emergency, no matter how crazy you think the call is, you cannot justify that kind of behavior. So you simply must stop at every intersection. Now, do you get more leeway because you've blaring this siren and you're hitting this horn and all? Yes, of course, people are going to stop on a general basis, but do not blow through that intersection. You cannot be pulled over and ticketed for going through the intersection. If you blow through that intersection and everyone survives and you get lucky, that's legal, but it's stupid. If you hit some, so the way South Carolina law works, and most conservative states are like this, and there's a lot of positive to be said about that, is that we don't tend to regulate the hell out of people, but we do tend to regulate the hell out of the outcome, which is a big statement. We don't tell you how to drive that ambulance when it's emergent, but we will do something with you if you get it wrong. That is how South Carolina looks at it. They don't tell you how to raise your kid, but if something happens to your kid, your butt's theirs. You belong to the state. And that's kind of the same way we look at ambulance driving. They don't tell you how fast you can go. They don't tell you which intersections you got to stop at and which ones you don't. They just say, if anything bad happens, it's your ass. So, because of that, you've got to get that strong conviction inside of yourself to say, what is a reasonable risk? What decision making running emergent is a reasonable risk? And so a lot of services have gone out and done tier level responses: Alpha, Bravo, Charlie, Delta, Echo. You've probably heard that on your ride alongs. This is a Bravo response. Well, what does Bravo mean? Well, Alpha means don't go lights and sirens at all. Just go to the call, take your time, drive like normal, be a regular person in traffic. Bravo, Charlie, Delta, and Echo are increasing levels of, hey, this is bad. Get to the call the best that you can, the safest that you can, but you should hurry. That's how that works. The data is very bad on emergent driving. It's very bad for law enforcement, for EMS, and for fire. It's very bad. So the tier level response is attempting to at least put some of that data back towards our favor by reducing the amount of time we spend running emergent, if that makes sense. For the ambulance aircraft stuff, you want to be 100 by 100 is the space. And so that's what you need to be thinking about for the test question, 100 by 100. Okay, 100 by 100 is what we need to land. When do you call an aircraft? Well, that's made by your service. Most commonly, it is for STEMIs, strokes, trauma, and anyone who's entrapped, someone you can't get out, you can call a helicopter. and if you need things that your service doesn't provide. So say that you are a BLS unit working out in Guatemala Island. There is no ALS out there. It's just you and your partner, right? Well, maybe you just need ALS skills. Maybe you need an IV. Maybe you need some fluids. Maybe you need some blood products. Then call a helicopter because they'll be able to get to you fast. They'll be able to transport the patient fast. So if you're a long distance away from the hospital, that's a reason. If the patient is really, really sick, that's a reason. If the patient is entrapped, that's a reason. The helicopter can tend to do more things than the 911 ambulances. We can do some surgical skills that they can't do. We have blood products that they don't have. We have medications that the 911 ambulances do not have. So those are reasons to call an ambulance. To land an ambulance is typically done by the fire department. When a medic unit or an EMT unit says they need an aircraft, dispatch says okay and sends a fire truck to go man normally a predestined landing zone, and you just go drive your ambulance with the patient to the landing zone, which should be 100 by 100 feet. That's a test question. So fire departments usually handle the landing zone material. I sent you guys a link to the landing zone training class that we put on at Medicare Air. So if you're interested in that, that link is on GroupMe. Totally don't have to watch it. It's an hour long, so you don't have to, but it gives you a lot of information about how we establish acute landing zones should a helicopter be needed. Let's talk about some safety stuff, okay? You do not ever go behind a running aircraft. If we see you move towards the tail rotor, we're going to tackle you. The most dangerous spot on the aircraft is the tail rotor. That's what kills people because it's at your height, okay? The tail rotor will chop you into little pieces. And if you're really morbid and you have nothing else to do, there are a couple YouTube videos that have yet to be banned of people actually running into tail rotors. So you can go see why they're freaking dangerous. So if you can see my red bubble on the screen, where I am pointing a line, a vertical line, is called the horizontal tail stabilizer. It's a little fin that sticks out of the tail of our aircraft. No one, including us, ever goes past that horizontal stabilizer when the aircraft is running. We don't do it. There's no reason to do it. There's no operations that happen back here. So do not ever go towards the tail rotor. When you approach an aircraft, make sure you have line of sight with the pilot. Typically, you would never be approaching the aircraft on your own. We will come get you. You do not ever come up to the aircraft. We will come to you. You need to know that aircrafts should be on flat level ground and not on a graded surface. You need to know that the blades can dip anywhere between 4 and 6 feet depending on the airframe if the blades are in a certain capacity. I can't explain all of that to you because it would be too much work, but there are times in which the blades can move up and down, which means your little head might get chopped off. That is not very common, and it's not super true of modern aircrafts. Example, the aircraft that I work in, there is almost no scenario in which you need to duck or hold your head low walking underneath our rotor system because our blades are 13 and a half to 14 feet in the air. So with that said, you don't have to wonder about the what ifs because you shouldn't be approaching the aircraft. We will come get you. And obviously, if we're doing it, then it's safe to do. You're going to always see us walking around the front of an aircraft. You don't see us going towards the back of an aircraft. Now, we might be over here underneath the space where the patient is loaded, but you will not see us operating around that tail boom. So think about that. If we tell you to stop, you stop. This is also bullcrap, much like the sign language was. We do not pay attention to this, and here's why. Every branch of the military that has an aviation wing has their own signals. So then what the hell of use is it? If Bob, my Navy pilot, won't understand what Peter, my Coast Guard pilot, understands, then it's all bullshit. And in this case, it is. Don't do this. You look really silly. We make fun of you all the way to the ground. We'll probably take out our phone and video it. So don't be this person, because we are laughing at you loud and clear. You can't hear it, but there are jokes being made. Night landings, don't turn on your lights and point them towards us. We're wearing night vision goggles, military grade night vision goggles. If you flash us in the goggles, it blinds us not for a few seconds, but probably for a few minutes, which means we're going to lift up and leave. We're not going to land because it's not safe to do so. So here's the deal. Your vehicle's lights should be pointed at the spot you want us to land, but there should be no lights pointing up towards the aircraft. If you have a flashlight in your hand and you get the urge to point the flashlight at the helicopter, just go ahead and put that flashlight on the ground. Okay? I don't know why people want to point flashlights at helicopters, but occasionally the oxygen level at ground space is different than that's in the aircraft, and you guys don't think it through. So do not shine your freaking flashlights at the aircraft. It will blind us. We're wearing night vision goggles. Here's the grade that we talked about. Never approach an aircraft on grade because the blades are much lower. We can't account for that. Again, not a problem if you never approach an aircraft without a flight crew member going to get you. We will sometimes come and get you because we need help. The patient's dying or something's happening and we need help, but don't do it on your own. Landing zones should always be uphill and upwind if at all possible. You're going to see that on multiple test questions, uphill and upwind. All right, here we go. Let's review. All the following are examples of standard patient transfer equipment except, this is a common question. Which one of these things would you not find on a typical everyday ambulance? Come on, people. Wake up. Oh, Lord. Do y'all hear me? Hello? Okay. Whew. Thank God. Truly just saved my life. No, a Stokes basket. Long backboards are on an ambulance. Stair chairs, which are wheeled stair chairs, they're on an ambulance. And the stretcher is on an ambulance. You don't see Stokes baskets on an ambulance. A Stokes basket is that thing you see off the side of a helicopter. It's what lifts people out of the mountains and off of boats into the helicopter. We carry those on fire trucks. So a Stokes basket can be used to get someone out of a field, to get someone out of the woods, to get someone off of an incline, off of the mountain, out of the boats, out of the water. That's what a Stokes basket is. It's not common on everyday ambulances. The purpose of a jump kit. So a jump kit is the same as your first in bag or your 5-minute bag. What's the answer? Yeah, D. Thank you, Sherelle. 5 points to the people who are showing some love. D, your jump kit, also known as the first in bag, also known as the blue bag, the red bag, the green bag, whatever the hell your service has. That's what you will need in the first 5 minutes. Typically, you would see BVMs, blood pressure cuff, SpO2, maybe a couple medicines, your Narcan, your Epi, your BVM, a tourniquet, occlusive dressings, whatever is life-saving. That's what'll be in your suction. That's what'll be in that first in bag. Now, some places go all out and that thing weighs 75 pounds. And then some places really do try to do it right and only put in that bag what you would need to save a life right now. You have been dispatched to a call for an unresponsive patient. What is the most important information you want to obtain from the dispatcher? This is kind of similar from chapter 1. Like, what is the most important thing that we need to know if we're responding to a call? Yeah, where is the patient? No matter what's going on with the patient, if I don't know where you are, I cannot help you. So D is the answer. While en route to a call of a major vehicle collision, the most important safety precaution you and your partner can take is what? This is pretty easy. Put on your seatbelt. Put on your seatbelt. You should not be operating in a moving vehicle without a restraint. Which of the following is not a guideline for safe ambulance driving? Always use your siren if you have the lights on. That's great. Always exercise due regard. That's great. Use one-way streets whenever possible. That's stupid. Go with the flow of traffic. That is great. C is the answer, and that brings up another topic. If you get in the opposing lane of traffic, you better be careful. There are multiple agencies and even state laws that require supervisor permission to go into opposing lanes of traffic emergent because it's an obvious increase in risk. That traffic is just going on about there daily, and supposedly there's not supposed to be anything coming against you, against your flow. And then suddenly there's an ambulance. So inherently, going in the opposing lane of traffic is extremely dangerous. Sometimes we have to do it, but you need to do it with great care. You should be driving really slow in the opposing lane of traffic. And guys, we still see some dumb stuff. We see people get in the opposing interstate lane of traffic with a couple moving vehicles because when a big wreck happens, that lane of traffic will stop moving. But you don't know how many cars got around. You don't know how many cars were ahead of the accident. And so if you just jump in the opposing lane of traffic and run 70 miles an hour up that lane, that's a disastrous recipe. It just doesn't make sense. You got to be really careful with that. At what speed will the ambulance hydroplane? Well, there you go. There's that question. On a roadway. And so their number doesn't quite match mine. So I would definitely be between A and B. And since A is the smaller amount, I'm going to go with A. It's probably B. It's B. So they're saying 30 miles an hour. I think this is heavily dependent upon the weight of the vehicle you're in, the driver that's in the seat. So this is probably a statistical data question that, the answer is pretty crappy for. But that's their answer, so memorize it. 30 miles per hour is what they're saying is the speed, the only speed you need before that vehicle will start hydroplaning, which is almost no speed at all. So the most common and often serious ambulance crashes occur at what? Intersections. There's a great documentary, I think it was done by 60 Minutes. In the 80s, a paramedic was one of the first people to be criminally convicted of the deaths of an intersection family that he struck going to what was a disastrous call. They were responding to a motor vehicle accident with quote, bodies everywhere. That's what the dispatcher told the ambulance crew, who had been on duty for an extended period of time. And so, Droovy, they blew through the intersection and they struck a vehicle and killed the people in that vehicle. And he was one of the first people to go to jail for doing that. He was a paramedic. And his story, he is now much older and he is a free citizen. Obviously, he no longer can practice as a paramedic, but he tells his story because he said the lesson for him is one he can't ever get back. And he was hoping his story would speak to new responders and show what could happen if we let those lights and sirens do the driving instead of our brains. We need to be emotionally mature. We need to be cautious and careful and deliberate. Do not ever blow through an intersection. The recommended helicopter landing zone space is what? Easy peasy, 100 by 100. Which of the following statements about helicopters is true? Okay, A was straight out of the material. It is possible that the main rotor blades can dip 4 feet. That's variant depending on the aircraft. But it is true that depending on what the pilot is doing, depending on whether the blades are running full speed or not full speed, they can dip down. Winds, grade, all those factors come into play. They can dip down. So A is true. B, a helicopter is considered hot when the rotors are still. That's not true. An aircraft is considered hot when the blades are turning. If the helicopter must land on grade, you should approach uphill. No, that means that you would run into the helicopter's blades with your head or your legs. Both of them are stupid. Don't do any approaching of the aircraft on a grade. If you must go from one side of a helicopter to another side of the helicopter, the best way is to duck underneath the body. False. The best way is to go in front of the aircraft to maintain complete and constant sight of the pilot so that they know what you're doing and they can stop you from making a mistake. So the answer is that the blades can dip down. Upon arrival at a scene where hazards are involved, where should you park? Yeah, babe. Upwind and uphill. Upwind and uphill. D is wrong because it should be 100. And here's another one for you. You should park 500 feet from any scene considered to be unsafe. You should be 100 feet from any regular scene. You should be 500 feet from any scene that's deemed to be unsafe. Keep those numbers in mind. That concludes tonight's lecture. Thank you for staying with me through this boring material. Well, it's not all boring, but it is hard to sit through a long lecture. So I appreciate you. Let's check out on the sign-in sheet. Make sure it's all good to go. I have Eder, Sherelle, Sydney, Julia, Mark, Alex Clark, Max Alderman, Dominique, Lavelle, Diaz, Patel, Lemon and Ormond, I got you, but you were out at a certain time, so you might have to do a lecture assignment. So, finishing this, the lecture assignment will be, which part of the aircraft is YouTube showing some really intriguing and interesting videos on? Which part of the aircraft shows some gory, horrible ends of life on YouTube? That'll be our lecture assignment question. Don't hate the messenger. I just happen to watch the videos in training to know not to run into the rota myself. There's some pretty good ones, so don't tell anyone I sent you, and don't be watching them on repeat. Make sure you're not on a company Wi-Fi. That concludes tonight. I love you guys dearly. I will see you in skills. I will not be at Wednesday. Excuse me. I will not be at Thursday because this week I fly Tuesday, Thursday. So I will not be at Thursday. I will see you Wednesday. Bye-bye. Bye-bye.
Thank you. Good night.
Good night, Drewby.
You are currently the only person in this conference.